Thank you very much for inviting me to speak at this virtual conference. Seems to be going extremely well. Very interesting discussion this morning. I'm going to be talking about the Heart UK consensus statement on homozygous familial hypercholesterolemia, which came out in 2016. It's open access, so all the details can be looked up if people wish to. Okay, I'm showing this front copy just to show you the number of people that are involved. They're all in various ways experts in all aspects of lipids and care of people with familial hypercholesterolemia, in particular homozygous familial hypercholesterolemia. So the aims of the actual consensus statement, the primary aim actually was to provide a care pathway which incorporated new treatments, which at that time were lamicipide and evolocumab, with the existing accepted treatment, which was LDL apheresis and conventional lipid-lowering treatment. We identified the need to make sure apheresis, that's LDL apheresis, was more generally available. Particularly from a geographic point of view, because it's don't want people traveling too far. And to align aspirational treatment targets for cholesterol lowering in homozygous familial hypercholesterolemia to that which exists for heterozygous familial hypercholesterolemia, which is clearly a huge challenge, and that's why they're aspirational. It's a challenge for two reasons. One, the cholesterol is very high, and two, their LDL receptors are to a varying extent non-existent, and most conventional cholesterol-lowering treatments operate by inducing the synthesis of LDL receptors. That's the peculiarity of homozygotes. Now, in terms of the care of homozygous familial hypercholesterolemia, I've identified, and I would like to get that reviewed when we do review the statement, of the early history of homozygous familial hypercholesterolemia. Now, there are many, many case reports in the literature, and this is one, unfortunately, is somewhat typical of the sudden death of a 4-year-old. And what this picture shows is his left anterior descending coronary artery, which is completely occluded by atheromatous plaque. He was known or suspected of having homozygous familial hypercholesterolemia clinically, and his LDL cholesterol was sufficiently high in a child to consider it. Now, one thing of great interest is the mutation was reported in this paper, which is known to be a mutation which gives a virtual deficiency of the LDL receptor, and which you can predict that atorvastatin and ezetimibe, with which was treated, will be more or less ineffective. So there are other guidelines, and in many respects, our consensus statement accords with the European Heart Atherosclerosis Society guideline, but obviously that was before lamicipide was fully developed. So the key areas that I've decided to focus on are the genetic basis of homozygous familial hypercholesterolemia, the role of genetics in diagnosis, and the interplay between genetics and the phenotype, which is now known to be more variable than hitherto thought in the heterozygotes and possibly therefore in homozygotes. I've identified a key area to my mind, which is the possibility of survivor bias, in that most clinical trials are dealing mainly with adults, and they've obviously survived childhood, and I'm a bit concerned about early mortality. Now, obviously, pharmacotherapy is more than adequately covered by some of the very distinguished co-presenters, and I'm only going to use that to illustrate points. In terms of limitipide, there's an ongoing monitoring because of the predictable effects of limitipide in causing fatty liver, and it's important to support that, and I'll just mention that briefly. So I'm also particularly interested in extending pharmacotherapy into early childhood, and the monitoring of atherosclerotic cardiovascular disease in children at an early age in the context of homozygous familial hypercholesterolemia. So most of the people will know this already, but familial hypercholesterolemia is primarily an autosomal dominant condition, and caused, as I say there, by mutations mainly in the LDL receptor, but it can be in various combinations with other things which I mentioned there. There are rare other causes which should be considered if genetic testing in the first line doesn't reveal them. But most genetic testing actually covers the LDL RAP1 as well, in the UK anyway, but not the ApoE deletion at the moment. I think that's planned. So the important thing about international criteria for diagnosis is that it still includes sort of phenotype diagnosis. That's where the alls come in there. And I'm not at all keen, personally, on not doing genetic confirmation, particularly in homozygous familial hypercholesterolemia, primarily because it makes things very clear, and uncertainty is a bad thing in making difficult decisions in terms of treatment. So I think obviously genetic testing should be comprehensive. And when considering the genetic services that are being put in place, it's also important to consider the polygenic score, which is really to suggest an alternative diagnosis in the event of a negative genetic test for homozygous familial hypercholesterolemia. Obviously, some information is extremely useful because it's an autosomal dominant condition, and if both parents are heterozygotes, then there's a 1 in 4 chance that a patient with familial hypercholesterolemia would be a homozygote. So xanthomas remain a strong indicator. Now, if everything doesn't fit together only, then you should think about other causes of xanthomatosis and high cholesterol, which I've written those down there. Okay, so looking at the UK situation, the LDL receptor mutations are the vast majority, and there are various combinations with the other important genes. In terms of the LDL receptor, obviously there are classically 5 different types of mutation affecting function. But the important thing is the residual LDL receptor activity. That is the capacity of the LDL receptor to actually work. And I often describe homozygous familial hypercholesterolemia as an evidence-free zone, by which I mean if you're only going to rely on controlled trials, then there aren't any. So it's mainly cross-sectional data that you have to base your decision-making on, and the acceptance that very high cholesterol confers extremely high cardiovascular risk in this condition, and that lowering LDL cholesterol will be beneficial. So Rahl et al. Looking at this as an international study, it did involve the UK, did show that there was a relationship between LDL receptor activity and pre-treatment and post-treatment LDL cholesterol, which is exactly what you expect. But so evidence to that effect does exist. And again, because evidence is hard to come by, you have to take what you can. And so there's been another cross-sectional study of 25 years of follow-up, looking at almost every conceivable form of cholesterol lowering treatment, including those which are no longer allowed. And it does show that your outcome is very much dependent, and this is in homozygotes, on the achieved LDL cholesterol, which again is exactly what you expect. Now, the point about that is it should determine health policy. In the event of lack of controlled trials, those facts should determine health policy, given that you need to demonstrate at least safety. So one of the key concepts of treatment of homozygotes is or familial hypercholesterolemia in general, is the cumulative LDL cholesterol exposure, which is it's outlined. This is after Weigmann in the European Heart. I think it's a Heart Journal. I can't see it on my photograph. Now, the extra bit I'm going to put in here is this pink bit. And the pink bit is imaginary, but I'm raising the possibility that there is a group of homozygous familial hypercholesteremic patients who have an accelerated poor clinical course and in fact succumb to the disease in early childhood. There's a little bit of a window in that sort of area where there's a lack of real data. The main problem is, first of all, homozygous familial hypercholesterolemia must be more common than we hitherto thought, because heterozygous familial hypercholesterolemia is more common. And we don't know enough about the early pathway or experience of young patients up to the age of 10, because we don't know how many people are actually involved. We don't know the denominator, in other words. So it's important in this situation to make a risk assessment based on the height of the LDL cholesterol, the presence or absence of atherosclerotic cardiovascular disease and other risk factors. I mentioned lipoprotein a there, which has not been shown to be an additional risk factor in adults. Mainly it is thought because the LDL cholesterol is by far and away the most important, and it shadows it out. But it could easily be important in the developing child, when the vasculature is developing in children. So in terms of putting all this information together, making decisions that go back from to 1-2 years to prevent this kind of thing, then it's important to have an approach which is very sort of consensual, and we have emphasized the issue of co-determination, which is sharing all this risk with the patient's parents and also with other professionals. So that's a feature of the consensus statement. So this issue of survivor bias is based on, it's at the moment speculation, but I think it would be amenable to study. The prevalence of homozygous familial hypercholesterolemia could now be estimated at about 1 in 300,000, as opposed to 1 in a million. The known prevalence is actually about 1 in a million in the UK. So there's considerable undiagnosis. There's no survival data from birth, just anecdotes and case reports. And so studies based on adults may be looking at survivor cohorts. So in terms of treatment, we've always accepted in Heart UK that the LDL apheresis is the best initial treatment in children because it's safe. There are some problems of acceptability. I mean, that's obviously technically difficult in very young children. There is still a problem of vascular access, which is a subject of debate across centres which deal with apheresis. The issue really is that the flow of blood through the shunts fistulas doesn't seem to be adequate to properly arterialize them, and they fail quite often. So one of the treatment options is high potency statins. Now, we've had an excellent talk about the mechanism of drugs, but statins work indirectly by inducing LDL receptors. So high potency statins will have a limited effect in homozygotes, as well as etomide, cadocevilam, and PCSK9. PCSK9 particularly is dependent on residual LDL receptor activity. Now, lamiptide, and I'll discuss mechanism later, acts independently of the LDL receptor by reducing the production rate of VLDL and subsequently LDL cholesterol. I'm going to talk about aspirin because it's not covered adequately in many guidelines, and also about liver transplant. Now, liver transplant is quite common on a worldwide basis as a treatment for homozygous familial hypercholesterolemia, but it's very much treatment of last resort and shouldn't be used in any other way in the UK. But it is there if everything else fails. So, looking at new treatments, I've focused on vinolizumab, I think it's called. It's covered, but it's a new drug which is originally developed to improve lipoprotein lipase deficiency, but it has an effect of reducing fatty acid delivery to the liver, reducing VLDL production, therefore lowering LDL production. So that's another drug which is coming along. Now, most of the things that we discussed with Calteret were not actually likely to work in homozygous familial hypercholesterolemia. So you need drugs which target VLDL production by the liver. So evinacumab is in fact in a phase 3 trial and is under active consideration by NICE. And I note that its age limit under NICE scoping is older than 12. So it does look a promising addition to the treatment. So lamiptide, those who don't know, is an inhibitor of VLDL assembly in the liver and also in the gut. And it's a small molecule. It has a predictable effect on increasing the fat content of the liver, which seems to be something which can be managed with dose adjustment. So the lower registry has been set up for long-term safety and efficacy of lamiptide, but it doesn't actually include subjects under 18. Again, there's case studies which are being published, which are relatively small numbers of people. I think it's fair to summarize that both avenues have not revealed any surprises. Lamiptide causes fatty liver and it can be managed. So this is extremely important, and we need to be grateful for Amrit Pharmaceuticals for pursuing this. There's a trial of lamiptide which is planned in children, and if you notice in the sort of recruitment phase, it's stratified to include children from 5 to 10, 11 to 15, and 16 to 17. So particularly the 5 to 10 will allow people to more easily make decisions about introducing lamiptide at an earlier stage. It may not even then be early enough, but at an earlier stage. So thanks to Helen Phillips of Amrit for providing me with that information. Okay, turning to aspirin. We did make a statement about the use of aspirin in homozygous. It's based on the idea that they're almost certain to have atherosclerotic disease, and therefore aspirin is known to be beneficial. National guidelines have recently been tightened up. So it's interesting to think, how do we interpret guidelines based on non-FH in terms of FH, and particularly homozygous FH. So we would say it's as per national guidance for secondary prevention in those over 16. Now, basically, aspirin prescription is based on an assessment of benefit of risk of bleeding versus the benefits. And children with homozygous familial hypercholesterolemia are at high risk of atherothrombosis and low risk of bleeding. So that's the basis of our recommendation. As I say, it's not being considered by other guidelines. So it may be something which we would prefer some greater sort of peer review of. So the issue of liver transplant, which is there if we cannot intervene satisfactorily in patients where, for one reason or another, we decided that the clinical course is so bad that something heroic has to be done. So the problem with liver transplant in the UK and many parts of the world is a shortage of donors. But I've spoken to various transplant specialists, and the main thrust of what they say is that they would more readily do lobe transplants from related donors. So that would convert the homozygous person into a heterozygote, and then they would then be amenable to treatment with conventional lipid-lowering drugs. And looking at that particular series, an 80% reduction in LDL cholesterol in a homozygous series of patients was achieved by liver transplantation. So it is rare in Europe, but there is data in the European Liver Transplant Agency. And I think it would be important to audit that data to see how such patients do, so that we can consider liver transplant as a treatment of last resort. So for the future, when we look again at the consensus statement, I think we'd like to look at mortality data in children, defined in this case under 18 years of age, and we'll have a better handle on the denominator based on genetic diagnosis. So people with homozygous familial hypercholesterolemia on the whole do stand out in some way, and so you should be able to ascertain relatively easily how many homozygous familial hypercholesterolemia patients there are. And that will go along with better genetic diagnosis of familial hypercholesterolemia in general. So we will need to look again at the vascular access issue for apheresis, and continue with the monitoring of the effectiveness of liver transplant and the safety of limitabide. So when Heart UK acts as an advocate for better treatment of patients with homozygous familial hypercholesterolemia, it has to argue on the basis of data largely done in patients without homozygous familial hypercholesterolemia, and that will be the case for evinacumab and other treatments of a similar type which will come along in the future, but it looks possible that they will come along. The particular issue with treatments which are reserved for homozygous familial hypercholesterolemia is that because it's a relatively rare condition, that they will be expensive. So the crucial argument to be put is to balance the expense and the safety of the drug against the clinical consequences of ignoring accelerated atherosclerotic cardiovascular disease in very young patients. And so we need to put more effort into ways of bringing forward treatment, effective treatment in very young children. So thank you very much.
Thanks very much, Mike. That was really clear and a great overview. We've got a couple of questions. I just wanted to ask one quickly before we move on to the Q&A, and that is this very concerning issue about a misdiagnosis in a child which could result in the death even in someone under 5 years of age. Heart UK, as you know, is advocating child-parent screening to identify familial hypercholesterolemia in babies at the age of immunization at 1 year of age. And clearly this would provide a reliable means of identification of homozygous FH before most of the consequences. So I just wonder whether if we were in that situation, you know, what are treatment options? How young can you start LDL apheresis. This is also a question that's on the Q&A from Fuzia Sadiq. So realistically, you know, how soon can you intervene if you identify a child at 1 year of age with homozygous FH?
Yeah, well, in our consultations with pediatric specialists, they gave an age of 2 years, but it's partly size dependent. So it depends on how large children are. But yeah, I mean, it is adjusted in terms of flow rates and things for the size of the patient per kilogram apheresis regime. Well, so yeah, it can be done from the age of 2. Yeah, I mean, it's accepted as being done from the age of 2.
The next question that was on here is about limipide, given that it works by inhibiting the MTP, and as is also deficient in A-beta-lactoproteinemia, you're expecting fat-soluble deficiency. Vitamin deficiency might be an issue, and is this a problem for patients? Janine may talk about this a little bit later, but maybe you just want to say something about that.
Yeah, I don't really know about that actually. I mean, obviously it is a consideration. And I haven't looked in detail at the lower registry, so that they will have it. But it's because my main interest was in children, so they will have details of that sort of thing in the lower registry, which I'll give them the reference, I think.
Yeah, just in relation to the children again. So underweight children would basically have to wait till they're gained weight to be apheresed, I suppose, is the obvious.
Yeah, it is. It's a question of size, but I think most the main problem, to my mind, would be it's quite an invasive procedure, and it's a regular procedure, and it's not. I don't know that it's particularly well tolerated by small children. Particularly with the issues of vascular access. So it's not straightforward at all.
And finally, the question from Charles, how much data is there on combined heart and liver transplant? Obviously, the very, very last resort.
Yeah, it normally actually is a combined heart and lung transplant. Again, I'm not...
No, they said heart and liver, I think.
Oh, heart and liver, sorry, no. No, okay. I don't know anything at all about combined heart and liver transplant. I mean, the whole point of doing the liver transplant is to cure the condition.
Sure.
It is unusual. It's the only condition in which a healthy liver is the problem. So I think you keep your healthy liver and you add in a lobe of liver containing the gene for LDL receptor.
Well, thanks, Mike, for that. I think we have one final question from Chris Byrne about bempedoic acid and limipide, but I think we can leave that for Janine to tackle in her talk.
Absolutely.
Yeah, Handrian wanted to ask a question live as well.
Okay, Handrian.
He did raise his hand.
Thank you. Sorry, I can't see the raise hand icon on my screen. So one area, I mean, excellent presentation, Mike, as usual. One area which we do differently is if we should routinely screen patients with homozygous FH who are not known to have an atherosclerotic cardiovascular disease with some sort of vascular imaging, and if yes, which one do you recommend? Because I know some other centers, they do this, and if they are secondary prevention, probably it is less of a problem because they will be under care of a cardiologist anyway. So,
yeah, absolutely. Well, I think that's the view we took in the consensus, that because it's a rapidly changing field, then it's much better to involve a cardiologist in the care and allow them to make decisions about the best way of doing the imaging, rather than us trying to keep up with somebody else's specialty.